Okay, as everyone's filing in, I'm just going to wait another minute before we begin. Okay, wonderful. So welcome everyone, and thank you for attending our fourth CASPR webinar session. My name is Laura Canoy, and I will be the moderator for today's session. Briefly, I'm a postdoctoral associate for the Pepper Partnership and the COPE2 studies, both of which are being led by Dr. Fiona Webster at Western University in Canada. And I've also helped to co-found CASPR with Fiona. So we have an excellent panel of speakers today who will be talking about the critical importance of gender within pain scholarship. And we have set aside time at the end of the session today for Q&A. So if you could please be sure to submit your questions to the panelists through the Q&A function. And this can be done throughout the presentation as well, which will help to ensure that we meet the time for today. And I encourage all of you to submit questions throughout the webinar. So if we do run out of time, and if you are a CASPR member, you can also continue the conversation with our presenters in our discussion board on the website. And for those of you who are just learning about CASPR, please be sure to visit our website at criticalpainscholarship.ca. And also please be sure to follow the COPE study on Twitter to stay up to date on CASPR webinars and other news. So the Twitter handle for COPE is at @COPE_study. So our first speaker, Dr. Kate Rice, is unfortunately unable to present today. However, we will be uploading a separate recording of her presentation to the website at a later date. This talk will be based on the secondary analysis of results from the COPE2 study, which uses institutional ethnography to explore the experiences of people living with chronic pain and systemic and structural marginalization. So for those of you who are interested in watching her presentation, the title will be Beyond Sex Differences, an ethnographic study of women's experiences of chronic pain and marginalization. So I would now like to introduce Dr. Jane Pryma, who is an assistant professor of sociology at the University of Connecticut. She's completing a book manuscript entitled Pain Mismanagement: The Rise and Fall of a Right to Pain Relief, which analyzes how pain expertise in the United States and France developed differently around a new human rights claim. Jane's past research has focused on the racialized and gendered experiences of chronic pain patients, mobilizing theories of intersectionality and moral boundary work to examine how chronic pain is recognized as a disability. Her work has been published in the American Sociological Review, Social Science and Medicine, and the Journal of International and Comparative Social Policy. Thanks, Jane.
Thank you, Laura, and thank you to Fiona for organizing this webinar. It's really a privilege to present alongside my fellow panelists on this topic of gender and pain. And so when I was thinking about what I wanted to present today and how I was going to organize this presentation, I identified a common thread that runs through my research on the politics and science of chronic pain. So I'm primarily a sociologist of knowledge. So my work has looked at how different groups of actors understand or know that gender affects chronic pain. In my short presentation today, I'm just going to give some quick snapshot findings from 3 related research projects, highlighting how 3 different groups of actors, patients, biomedical researchers, and pain specialists, diagnose gender as a risk factor or cause of chronic pain. I'll begin with how chronic pain patients tend to identify that aspects of their gendered social lives led to the development of their disabling fibromyalgia. I'll then shift to how biomedical researchers have examined over time the relationship between chronic pain and gender, shifting the focus, the mechanisms driving that relationship. And finally, I'll summarize some of my findings on how medical providers, in this case, pain specialists, in the United States and France, make sense of gender differences in their chronic pain patients' illness experiences and outcomes differently based on different political and medical cultures in the 2 countries. So when we talk about gender and chronic pain as social scientists, right, we make a distinction between one's biological sex, or sex assigned at birth, typically mapping onto male, female, and intersex categories, and one's gender, the socially produced practices, characteristics, and norms that we associate with femininity or masculinity. Until this point in history, the majority of biomedical pain science has usually assumed a congruence between a pain patient's sex assigned at birth and that patient's gender, meaning that the majority of biomedical research on gender differences in chronic pain typically classify men and women as people assigned male or female at birth, and will then examine how a mix of these people's biological characteristics and gendered social lives affect the development of chronic pain processing, and efficacy of treatment. So gender difference in pain experience is a really crucial subject of research for biomedical scientists, because demographic and epidemiological studies on chronic pain prevalence consistently demonstrate that women experience chronic pain at higher rates than men, and that chronic pain is the leading cause of disability globally. Unfortunately, there's been very little research to date on the experiences of transgender and non-binary chronic pain patients. And my research presentation today will really focus on this question of why women seem to present with chronic pain more often than men. But I do really encourage folks to remember to include transgender and non-binary folks in their future work, because this is a major area of growth, I think, in this area. So pain expertise still lacks strong scientific consensus around chronic pain's causes and mechanisms. And so in this sort of unsettled field of pain science, we've seen a lot of different actors try to make claims to explain what causes chronic pain and how gender might be related to chronic pain development. In 2022, the ICD-11 recognized chronic pain as a disease in itself, which was a very interesting and important move for pain specialists and pain patients who had been arguing for the medicalization of chronic pain as a disease in itself for quite a long time. But I think an interesting potential unintended consequence of this classification of chronic pain disease in itself is that it really does further medicalize and formalize chronic pain as a medical disorder, perhaps at times obscuring the social determinants or causes of chronic pain. And in this case, we can think about gender as being one of those social determinants. Because of course, when we talk about women's experiences of chronic pain, or what might be driving the fact that more women report chronic pain than men, we must also be attuned to the way that social systems of power beyond patriarchy intersect to shape experiences of chronic pain, systems including racism, capitalism, colonialism, ableism, etc. Sociological research, including my own, has shown that social actors and institutions disparately recognize a person's pain as legitimate based on that person's gender, race, class, culture, ability, etc. And we see these gendered and particularly racialized patterns of recognition and perceived legitimacy of chronic pain. So it's so important for us to continue to chart what are the root kind of social causes leading to the development of different chronic pain disorders, and not simply searching for biological mechanisms. So my research asks, how and why do different actors interpret gender disparities and differences in chronic pain management through science, practice, and policy? And given general knowledge of the high prevalence of chronic pain among women, my presentation today focuses on how first patients, then biomedical scientists, and finally clinicians understand why people who self-identify as women are more likely to report and experience chronic pain across their lifespans. So the first piece of research I'm going to focus on is work that I did interviewing 24 women with fibromyalgia in the United States who had sought disability accommodations or benefits due to chronic pain. I published an article out of this work in Social Science and Medicine in 2017. What I found in this research was that all of the women I interviewed reported facing doubt that their chronic pain was real and disabling, and they often attributed this to the fact that they were women, that there was this gendered dismissal of their pain as being, either an exaggeration or, hysteria. But beyond that kind of shared experience of the dismissal that their chronic pain was real and disabling, many, as they tried to kind of piece together the history of the development of their chronic pain disorder, described past psychosocial traumas, including domestic violence and sexual assault, and the burden of care work as precipitating their pain. And we can see how this, these specific types of trauma, domestic violence and sexual assault, and this idea of an excessive burden of care work are very gendered factors that these women were pointing to as being, as they understood as the causes of their fibromyalgia or chronic pain. So in recognizing, as all women were kind of recognizing that they had these complex histories of trauma or excessive care work that had led up to the development of fibromyalgia, there was a stark difference between the way that Black women and white women attempted to make their pain seem legible and credible to doctors, disability bureaucrats, and their social networks. So Black women consistently felt as though they needed to acknowledge racist welfare stereotypes. And in so doing, they felt as though that disclosing the trauma that they believed led to the development of their fibromyalgia actually lent their claims of disabling chronic pain more credibility in the face of disability services or doctors who were doubting them. Whereas the white women respondents I interviewed really believed that medical evidence alone could make their pain and disability credible and legible. So what this began to clue me into was this interesting way that chronic pain sufferers understand gendered forms of trauma as a cause of their chronic pain, but that the different racialized experiences of trauma and pain and the dismissal of one's pain as being real lead to women chronic pain patients as thinking about the relationship between chronic trauma and pain differently, and lead to disparate recognition and legitimation by doctors, disability bureaucrats, and social networks. So this led me into being very interested in how biomedical pain science itself has tried to tease out what is social about the relationship between gender and chronic pain. So I'm currently in the process of working with undergraduate research assistants to examine how biomedical pain scientists define and make sense of gender differences in chronic pain prevalence. So we're doing an analysis of 250 peer-reviewed biomedical journal articles published in English from 1990 to 2022. And what we've found preliminarily is that through the 1990s to the early 2000s, there was a lot of attention to the gender division of labor and gendered patterns of healthcare utilization or communication to explain why more women were reporting and seeking treatment for chronic pain disorders. But then we begin to see this increase in a neurobiological focus on common causes of addiction and chronic pain in women. And this is something that other scholars have noted recently in 2023 as well. And so what we're trying to investigate is how much of this shift to thinking about this nexus of kind of maybe a social root cause of some sort of social trauma that then leads to a neurobiological change that then precipitates the development of chronic pain, why that shift in focus might be linked to an increased concern around the prescription opioid crisis around 2010. Because we see after 2010 a quite precipitous surge in studies on neurobiological effects of gendered forms of trauma on chronic pain incidence and opioid addiction risk. So the next step of this research, after doing this initial analysis of kind of charting what the changing themes seem to be over time in this international body of peer-reviewed biomedical pain journal articles, is to think about the mechanisms of that change. So we're looking into research funding structures, the pots of money that became available to try to combat the opioid crisis, and also this increased pressure to include gender balance studies in clinical trials, randomized clinical trials for pharmaceuticals and different medical device innovation. So one of the implications of thinking about this shift in how biomedical pain science is trying to capture what's going on between the relationship of gender and chronic pain is that it can have pretty stark consequences for gender treatment disparities. So an example is that the opioid risk tool, which is used to screen the risk of chronic pain patients for developing opioid dependence or opioid addiction, was built off of research that suggested that women with a history of trauma are more likely to be predisposed to opioid addiction. And so as a result, what we can see is the under-medication in some instances of women with pain, with acute or chronic pain with opioids based on their reported history of trauma, which seems as though it is more of a compounding of gender injustices, right, rather than perhaps what we might like to see in terms of thinking about health justice and gender and chronic pain. So the next focus here is we're moving away from thinking about how biomedical researchers alone are understanding this relationship between gender and chronic pain, and into how pain specialists or clinicians on the ground make sense of gender disparities in chronic pain management. And here I'm drawing on my broader book project, which examines differences in how pain management expertise developed in the United States versus France. And what I find in an article published in the American Sociological Review is that opioids were very central to the development of pain expertise in both the United States and France, but that France more successfully held on to non-pharmacological treatment options and a multimodal clinic model to managing chronic pain, whereas the US largely fully defaulted to opioids as the primary tool to manage chronic pain. And one place that this plays out interestingly is when we think about how US pain specialists versus French pain specialists make sense of gender disparities among their pain patients. In that US pain specialists often define gender disparities in pain care in the US as related to opioid access and dosing. So they'll talk about the history of masculine default in opioid clinical trials, standard dosing and access, and how this can disadvantage women. And they'll also mention that women screen as high risk for opioids when they've experienced sexual trauma or domestic violence because they're predictors of both chronic pain and addiction, and how this can be, a powerful driver of disparate pain care. Whereas interestingly in France, where there is more access to different types of tools beyond just pharmacological opioid options, French pain specialists seem more attuned to kind of ongoing psychosocial factors that impact their patients' pain in gendered ways, often citing the experiences of isolated older women, women outside the workforce, and people with histories of sexual trauma, often women, who they argue take much longer to heal through the pain management process, and that the pain specialists themselves really try to encourage the kind of rebuilding of social networks, or the reinsertion of these isolated women into kind of social community to help them manage their pain. So we see these very different approaches to making sense of the problem or the root causes that lead to this high representation of women having either undertreated pain or particularly intractable chronic pain experiences compared to men. So some kind of final themes that cut across both US and French pain scientists and clinicians when I asked through interviews about how clinicians on the ground or pain researchers were hypothesizing why women are more highly represented as chronic pain patients than men. They talked about gendered healthcare utilization and the way that women tend to seek healthcare more frequently than men for pain. That there's greater receptivity among women to psychological and non-pharmacological therapies, whereas when men are encouraged to perhaps go to cognitive behavioral therapy to treat their chronic pain, oftentimes they'll kind of reject those more psychological interventions. They talked about provider bias and different treatment strategies based on the gender of the patient. And this was particularly true in France, as I just discussed, that pain specialists talk about taking more time with their women patients and thinking more deeply about what sort of structural or social conditions might be contributing to their women patients' pain. They also talked about the way that different occupations are gendered, patterns of employment are gendered, care work and social networks are gendered in ways that can lead to experiences of isolation or a lack of social supports that can worsen the experience of chronic pain. And of course, women's outsized experiences with domestic violence and sexual trauma came up a lot as well. So finally, I do want to draw attention to, despite the way that people on the ground, pain specialists on the ground, patients really recognize these very strong social determinants or social drivers of why women may be reporting chronic pain at greater rates than men, there's still a very strong turn, especially in the biomedical research, towards thinking about genetics and neurobiology, which recollapses the biological sex and social gender distinction in trying to understand what's going on in driving these gendered pain disparities. So very quickly, I will wrap up with thinking about where I'm going next with thinking about gender and chronic pain in my research. I'm currently in the very early stages of developing a project that looks at how in the wake of COVID-19 and social movements for racial and gender justice, some organizations have begun to move beyond the focus on biomedical diagnoses to recognize disability caused by social trauma. So within the disability study space, we often talk about a medical versus a social model of disability. And the gold standard has kind of been to think about disability as social, but the way that organizations tend to assess and address disability is often through medical diagnoses. But we're starting to see this shift to thinking about social trauma as being a driver or a cause of disability in itself without a biomedical diagnosis. And so I'm wondering if, in the way that we've talked about this nexus of social trauma and chronic pain and disability, if this is actually an interesting example of a demedicalization of chronic pain, that we're moving back in at least the disability space to really understanding social trauma as an impairment, as the cause of impairment. So what makes social trauma disabling isn't easy to evaluate with the medical tools and objective measures favored by bureaucracies to efficiently diagnose and accommodate impairment, which is what's made the identification and treatment of chronic pain and disability so challenging historically. So I think we're in this interesting moment where universities and employers in particular are assessing and managing the lasting effects of social trauma that are somatic through a disability rights framework. And I'm interested in understanding what potentially the unintended consequences of responding to social injustices in this way might be, while recognizing that it is this interesting way that we're seeing chronic pain simultaneously being medicalized in biomedical research, the ICD, but also demedicalized in some of these disability spaces. So thank you so much for the opportunity to share these very quick snapshots from across 3 different connected projects. And I look forward to any questions and to continuing the conversation.
Thank you so much, Jane. That was so interesting. Okay, so our next speaker is Dr. Christine Labuski, who is an anthropologist and associate professor of science, technology, and society, and women's and gender studies at Virginia Tech in the United States. She teaches courses about sexual medicine, queer tech, and ecofeminisms, and she also directs the Gender, Bodies, and Technology Initiative at Virginia Tech. She is also a founding member of the Mayapple Energy Transition Collective. Her book about vulvar pain, entitled It Hurts Down There, The Bodily Imaginaries of Female Genital Pain, was published with SUNY Press in 2015. Thank you so much, Christine.
Hi, everyone. Thanks so much for being here. And thanks so much to Fiona and to Laura for this fantastic set of seminars so far. And to my co-panelists, I'm really excited to share my work alongside you. I'm really delighted to have a chance to present these ideas to this group in particular, and I'm really looking forward to our discussion following the presentations. I'm just going to read a script. I was really just so concerned about staying to the time limit, so I'll be looking down a little bit more than I'll be looking at the camera, but hopefully when we're in a group discussion, that dynamic will shift a little bit. So now I'm having trouble. Here we go. Okay, so I wanted to start by providing a bit of history and context to the work that I'm going to discuss. I'm an anthropologist, and so I really need history and context before I talk about anything. Before I earned my PhD, I worked as a nurse practitioner for about 15 years, primarily in reproductive and queer health settings. My patients were almost exclusively cis women, and one of the things that I began to track, particularly among straight cis women, was a reluctance, a hesitation, and a sense of shame and avoidance that many of them had with respect to their genitals, their vulvas in particular. I became interested in the relationship between that shame, what I came to call vulvar genital alienation, and some of the conditions that I was managing, such as unintended pregnancies, sexually transmitted infections, even anorgasmia. When it was time to develop a dissertation project, I settled on this phenomenon of alienation, and I pursued ethnographic research in a vulvar pain clinic because I suspected that it would be a place where this alienation would be enacted. In other words, I came to this topic not via pain, but rather through how the ongoing experience of pain compelled some women to confront and maybe even reconfigure their genital alienation. So my study, the fieldwork of which I conducted in the mid-2000s, was an ethnographic study of a vulvar specialty clinic. The clinic ran for about a half a day per week, and I conducted participant observation for about 14 months. I observed over 100 patient visits, and I interviewed 41 women that I met through the clinic. I followed a smaller subset of these women into surgery and physical therapy sessions. And then I also spent non-interview time with several of these women, having lunch or coffee, going to yoga classes, meeting their husbands over dinner, which allowed me to situate their pain within some of their relationships and larger life contexts. I also note here a geographic or a spatial component to my project, because the women I interviewed came from all over the state. This was Oregon, and some even flew in for their consults, which is, so rare is the level of specialty care that they were receiving. And my drives across the state, to interview them, which often involved staying overnight, allowed me to gain a somewhat greater understanding of the resources that they were expending in order to seek care for their pain. Briefly, then, the vulvar specialty clinic saw patients with 3 types of conditions: vulvodynia, vulvar vestibulitis, and a group of autoimmune skin conditions loosely referred to as the lichens. These conditions were managed with various combinations of topical and oral medications, surgical excision of affected tissue, physical therapy, and sometimes sex therapy. And the waiting period, just to note, for an appointment at the time of my research to get an appointment with the clinic was about 4 to 6 months. And so though these conditions were distinct in some important ways, these 3 sets of conditions, a common denominator across all of them was chronic and life-altering pain. For some women, the pain was specific to vaginal penile sexual intercourse. For others, pain was exacerbated by activities like riding a bicycle or driving long distances. And for still others, it was wearing pants or sitting down. A main argument of my book is that vulvar pain should be understood as a dis-ease. And I've tried to define it here, but the idea is that the vulvar alienation that I describe and that I had observed over years as a clinician, a reluctance and shame shaped by patriarchal and misogynist attitudes toward the feminized physical genital body, compounds and increases the severity of physical maladies such as vulvar pain. In other words, the shame that women feel about their vulvas and their inability to talk about it, to sometimes say the word, leads them to delay seeking a diagnosis. At the time of my field work, the time span from onset of symptoms to a diagnosis was about 5 to 7 years. During this time, the particular condition that a woman has likely worsens, leading to what I'm calling vulvar dis-ease, an affliction that I insist is both a biocultural condition and a feminist issue. So on this slide, I've just tried to list some of the themes that emerged from my research methods that were specific to pain. The first is that the pain was heavily contoured by the relationships in which it existed, really the relationships that it disrupted. Second, vulvar pain is quintessentially heteronormative. Being unable to participate in what I call heteronormativity's signature act of penetrative vaginal penile intercourse led to many of these patients feeling like they were less than a woman. And it's important to note that this heteronormativity extended to providers who made a kind of a return, quote unquote, to vaginal penile sex, sometimes the main goal of treatment. It goes without saying, as Jane has just helped us to really start thinking about, that vulvar pain, like any pain condition, was intersectionally experienced, and race, religion, and straightness constituted dominant themes in my study in terms of thinking intersectionally. I've written a separate article about race and vulvar pain, and right now there's a group of Black scholars who are publishing lots of work about it. That's really fascinating. But I'll just briefly say that in my time at the clinic, vulvar pain was believed to be experienced primarily by white women. It was even being written about at the time in physiological terms of whiteness, but that this belief was influenced by at least some women of color being tracked into different diagnostic schemas. Additionally, securing a clinic visit required significant personal and financial resources that are often less available to populations who are multiply marginalized. Fifth, there was some disagreement, and still is, among providers about how best to understand and manage vulvar pain. That is it a chronic pain condition, or is it a form of sexual pain? And indeed, I witnessed a fairly spirited, loud-voiced argument at a vulvar pain conference about this very question. And I would say, likely alongside all of you, that, of course, it's both. And finally, vulvar pain was a driver of what I call in another essay, a kind of behavioral asexuality. And a phrase that I heard over and over again from the patients with whom I worked was that they had simply shut down sexually. Widening out to some more general themes, and alongside the whiteness that I just mentioned, vulvar pain conditions were also amenable to what we might call extra clinical interventions. Here I'm calling them linguistic, behavioral, and structural. Referring to a patient's recovering vulva, for example, as robust or as juicy, and talking with them about how to help it flourish were key behaviors that the vulvar pain clinicians with whom I worked routinely engaged in that helped women to recover from the alienation that was compounding their condition. I would also argue that patients who learned to make space in their lives for their pain, and this often needed to involve physical therapists who were particularly successful. So people who learned to make space in their lives for their pain had more successful outcomes than those for whom it was a hurdle to overcome. Patients who wanted nothing more than, quote, to never have to think about their vulvas again. This was something I heard frequently. And finally, treating vulvar pain conditions was a form of affective labor in which not all OBGYNs were interested in engaging. I saw this work as really truly avocational for the clinicians with whom I conducted field work. And I relate this avocational kind of mindset to how many areas of a person's life this pain disrupts and must therefore be addressed. So finally, my broadest theoretical take-home is that treatments for vulvar pain must be attuned to gender and sexuality. This is not news to anyone at this seminar, I think. In brief, heteronormative and penetrative sexual imaginaries and routines are profoundly challenged by vulvar pain, making room for all of us to imagine and enact a greater expansiveness in how we think about what constitutes sexual activities and the gender identities of those who engage in those activities. The vulva clinic physicians were so successful because they tuned into and cared for their patients' vulvas in all their complexity and queerness. And I say queer here, not because it was a term used by the clinicians, it was not, but because they treated vulvas as if they mattered in and for themselves. I maintain that vulvas are queer because they exceed the heteronormative confines of vaginas, anatomies that are often reduced to their role in reproduction or penetrative straight sex. Centering how vulvas are related to but distinct from vaginas and these roles was really key to helping them flourish. And so I'm ending on a sort of positive note, a really optimistic note, which is a grassroots organization that has emerged in the last couple of years called Tight-Lipped. If any of you are interested in vulvar pain, this is the first place that I would send you. This is a group of young people who the initial people who began it were people experiencing vulvar pain, sexual pain themselves. This has become, it started as a podcast. It's a really lively website. It's a lot of education among clinicians. It's a zine, it's all kinds of things. And so for any of you that are interested, again, this is the first place that I would send you. I do have a slide that is a bibliography slide, but it is not finished. But if anyone is interested in bibliographic references, I'll make sure that I get these slides to Fiona and Laura for people's consumption later. So thanks so much.
Thank you so much, Christine. It's a fascinating presentation. And I encourage all the attendees as well to please include your questions into the Q&A function. So our final speaker is Dr. Annalise Weckesser, who is a reader, which can be understood as associate professor for those who are outside the UK. She's a reader in medical anthropology at the Center for Social Care and Health-Related Research at Birmingham City University in the UK. Her research explores gendered experiences of reproductive, sexual, and menstrual health. She's also the co-founder and lead coordinator of SEEN, the Social Sciences Endometriosis Network. Thank you so much, Annalise.
Thanks. I forgot almost that I have to present. I was so engaged with Laura and Christine's talk. So I'm really looking forward to the discussion afterwards, and also feeling really fortunate for the theme setting that's already happened. Word like hysteria and the stigma around genitals are going to come out. So already seeing all these cross-cutting themes. So in the interest of time, I'll launch right into it. So up until relatively recently, endometriosis was actually considered a very rare condition, all the way up until the 1980s. But we know that it affects 6 to 10% of cisgender women around the world. So prevalence rates that are really, really very high, akin to diabetes, but comparatively receiving a fraction of the research funding, a fraction of general awareness. And also I always like to start out with saying, I myself do not have endometriosis, and I came to Birmingham City University with the good fortune of working with Professor, now emeritus, Elaine Denny, a sociologist who's been doing work around endometriosis in the UK since the 90s up till now. And it was my good fortune of getting the chance to work with her that I learned what endometriosis was. That was in 2012. And then after that, telling people what I was doing my research on, I actually found out that my maternal grandmother has endometriosis, 2 of my closest friends, and many, many of my colleagues. And just didn't know, just speaking to the silences that exist around endometriosis. There's no cure for endometriosis. There's been no breakthroughs in the past 3 decades. It's largely hormonal contraception or a keyhole surgery to remove endo tissue that grows on organs. I'll talk about that more in a moment. And patients face, on average, a decade before they'll actually receive a diagnosis. And here in the UK, sorry, I'm actually not in the UK at the moment. I'm in Poland, and my accent's obviously not English, but most of my research is in the UK. And the research from the UK shows that on average, patients have to go to a doctor about 10 times before they'll be referred on to specialist care. And then often in that process, they're misdiagnosed with having irritable bowel syndrome, sexually transmitted infections, and this all speaks to the very endometriosis, as they'll talk more about, is a really challenging condition to diagnose, even for health practitioners actively looking for it. And the symptoms can be quite debilitating, from painful menstruation to painful intercourse, infertility, really, really heavy menstruation for some, and various other forms of pain I'll talk about. And these impact every aspect of someone's life, and they're doing all of this, living through all of this for up to a decade before they get that diagnosis. And most of the qualitative research with patients, and most of the research done with surveys with patients and etc., show over and over and over again that patients report feeling dismissed, feeling that it's just in their head, and that they're just told it's just period pain. And based on this notion of it's in your head, we pull on notions of female hysteria. So we have this from Endo Monologues. Female hysteria? Why, yes, being misdiagnosed time after time does make me hysterical. And we have this quote from Nezat and al. Historically, if hysteria were cases of endo, then this would constitute one of the most colossal misdiagnoses in human history. One that over centuries has subjected women to murder, madhouses, and lives of unremitting physical, social, and psychological pain. And I'm going to talk about some of the historical framings of endometriosis. And from the 1930s all the way up to the 1980s, and there's a Times article called Endometriosis as the Career Woman's Disease. And that was based on this notion that it was only found amongst, or primarily found amongst, white, heterosexual, middle-class women that had, quote unquote, put off childbearing, that had sought to pursue their education and careers, and thus came down with the condition. And then this gave rise to this this persistent myth that pregnancy is curative, that if you become pregnant, that your endometriosis symptoms will become less and might not resume again. And unfortunately, we do have people reporting that they still hear this myth when they go to the doctor, that, oh, you might have endo symptoms, having a baby could help with that. In medical journals, endometriosis has often been called the enigmatic disease. And this is because its etiology still isn't fully understood and is still being debated. And another reason is because it doesn't fit standard biomedical models of disease. And what I mean by that is that the disease extent doesn't necessarily correlate to symptoms. So you could have some patients where they go and have their surgery and it reveals that they have lots and lots of endotissue that needs to be removed, but their symptoms didn't seem to be that severe comparatively. And in the reverse, you could have somebody with very little endotissue growth that needs to be removed, but their symptoms could have been quite severe. The classic definition, the one that you'll find most widely used right now, is endo as a gynecological disease. So again, it's where the tissue is found outside the uterus, growing on the ovaries, fallopian tubes, on the bowel and bladder, and it's been thought to be caused by retrograde menstruation, or period blood flowing upward through the fallopian tubes and into the pelvis, rather than out of the body and through the vagina. In the NICE guidelines, we use NICE guidelines in the UK. This will still be the definition of endometriosis that you will find there, and you will see it commonly even on endometriosis advocacy pages. But very recently, there's been a real shift, and I think Laura's talked about this, is looking at the genetic underpinnings. And right now, there's this piece done by Taylor, Kotler, and Flores in the Lancet, where there's really the shift to see endometriosis as a chronic, systemic, whole body disease. And the description of retrograde menstruation is now seen as outdated. And it's thought that endometriosis affects the metabolism in the liver and it leads to systemic inflammation. But what's really important about this is that the full effect of the disease is not fully recognized, and it goes far beyond the pelvis. That in our definitions of endometriosis as a gynecological disease, then often health practitioners will focus on the symptoms in that region of the body and overlook all the other symptoms that affect elsewhere. And that brings us to this slide where I finally get to the what are the symptoms of endometriosis? The four at the top are the ones that primarily do affect people the most in varying degrees, and the ones that are most widely known. So again, painful menstruation, heavy menstruation, infertility for some, pain during penetrative sex, pelvic pain, just general pelvic pain. But also, and what's less known, is pain with bowel movements, urination, ovulation, internal examinations, tampon use. Our research with adolescents showed tampon use a lot. And then also bloating, loose motion, bleeding in the bowels from the belly button, pain in your legs, knees, and back. I've come across that many, many times. And we know that GPs, general practitioner doctors, don't always recognize that as an endo symptom. And of course, fatigue and depression. So there's really this movement, especially around patient advocates, in depictions of endometriosis, of showing a whole body, rather than you often see articles or media articles about endometriosis just showing like somebody holding their pelvis, just like one region of the body. And there's really a movement away from that. So we're turning to the work that Professor Denny and I have done. We use this notion of contested disease, where we think sociologically around endometriosis. And by endo as a contested disease, we mean there's no consensus on its exact origins and etiology and cause, no consensus exactly on its treatment and how best to take treatment. And there's actually debates as well if it even exists as one condition, and that it might actually be a more broader spectrum that we're still trying to understand. And another thing that comes with contested diseases is contestation and debate over what constitutes typical versus atypical. And this really comes in with the pain and menstruation and trying to decipher when is period pain or pain around ovulation just quote unquote typical cramps, and when is it actually indicative of pathology and needing a referral. And then we also talk about how endo is this gendered quest for credibility when we do our research with women. And it's this quest for validation via diagnosis. that they have this long delay, long wait, and often getting that diagnosis is vindication, validation that it wasn't in their heads, and that diagnosis can become really, really important to them. And then again, all while navigating the stigma that surrounds menstruation, infertility, and painful penetrative intercourse that really challenge our notions of what it is to be an ideal woman. And these women's narratives of dismissal, when Elaine first collected narratives from women who have experienced endo in the 90s, it was all this, they told me it was this period pain. They did not listen to me. They told me it was an STI. They gave me antidepressants. We did a study in about 5 years ago, and this was after the UK introduced specialized endometriosis clinics, about 60 across the country. And even after that, we were still getting these same narratives. So that's what was really shocking for Elaine, is to see after 20 some years, 2 decades, that nothing had really shifted significantly, even after the introduction of endo clinics. And I have recently done some research with clinicians, both general practitioners and gynecologists. And I've got this one quote where the interviewee says, "It's endometriosis. It's not considered a priority diagnosis. As much as I feel for the women suffering from endometriosis, that's not going away. It's not a permanent damage to an organ or shortened life expectancy. It's life quality rather than expectancy." I want to flag that they're actually incorrect. Untreated endo can lead to permanent damage to your organs. So that was wrong. But what I did appreciate about this quote is this admission that it's not a priority diagnosis. So looking at some more like sociological theories around pain and endo and why this is happening, we've got Bendelow, who talks about, that we pulled on Bendelow, and who talks about gendered moral evaluation of pain within medical ideology, which defines emotional expression and experiences of pain as socially undesirable, whereas suppression through stoicism tends to be highly valued. And men in our society generally are portrayed as and believed to be stoical when it comes to pain, as less likely to go and report pain. So if they do, they must be believed. And then in contrast, all these binaries, right? So much fun. Women are thought to be more expressive and more likely to come forward and not feel vulnerable or fear of expressing their pain. And thus that works too, that their accounts are more likely to be dismissed. I also want to think through that more because we know of lots of other areas in life beyond pain where women's stories are not seen as credible as men's, and that's something that I'd like to explore more. And then there's this myth that women often report hearing too, is that women have this higher pain threshold because they give birth and everyday experiences of menstruation. So another reason why they might be dismissed. Also thought worth noting how all of this points to examples of medical misogyny as well, and the value of fertility. So many people I've interviewed have told me that they've gone to their doctors, sought referrals for what they believed was endometriosis and couldn't make headway. But as soon as they said that they wanted children, they would basically lie and say that they wanted children, but were struggling. Then they could get referred on to investigate what was going on, get that keyhole surgery, get that diagnosis of endometriosis and get the tissue removed and have some cessation from the pain symptoms for a few years. Also with a colleague who wanted a hysterectomy when she was 27 because her endo was so bad, she lost 2 months of every single month of her life. And she was denied that hysterectomy until she got into her early 30s because they told her you might change your mind and want children. Another thing that comes up is how patients become pathologized when medical practitioners are confronted with the limits of their own medical knowledge, because there are so many unknowns around endo, and doctors can be not wanting to admit that they don't know something. In the social position that we put them on, it's hard to say, I don't know, and let's find out together. And so in the face of that, there can be this, well, the problem isn't that I don't understand, the problem must be with you. And Young, Fisher, and Kirkman's a fantastic article on that, exploring that more. And then also just the general historic and present devaluing and neglect of women's health and research funding, and why we know so little about endometriosis. I wanted to, in this last few minutes, just call attention to an article, a conversation article that I have done with Daniel Perot and Veronique Griffith on Black women's experiences with endo and challenges, exacerbated challenges of accessing care. So back in the 90s, sorry, the 70s, back in the 70s, that's how long ago, there was already research and evidence to show that endo was being underdiagnosed in Black women. That was based in the US. And most of this research comes from the US. Very little, I don't believe we couldn't find anything in the UK, nothing in Canada. It was mostly in the US based. And the research shows, and all the citations are in that conversation piece, is that Black patients are 50% less likely to receive a diagnosis than white patients. And I've heard many doctors then believe that means that Black patients are less likely to have endo. They would mistake, well, if they're not diagnosed as much, then they must have it less, like prevalence rates and diagnosis. There's two different things. And we know that 72% of all diagnoses are with white patients versus 5% with Black patients. We know that Black patients are have to wait 2.5 years longer to get that diagnosis. And we also know they're less likely to receive a surgery to remove the endo tissue. What we do know in the UK is that patients from ethnically minoritized communities are more likely to have their endo symptoms dismissed. And in the article, we go more into the roots and what's underlying all of this. There's that longstanding myth that Black women are less likely to have endo, and that's based on that previous notion of the career woman's disease. And it was thought that because Black women have more children, or are more likely to have more children, they're less likely to have endometriosis. And then also, when it comes to pain and pain dismissal, we have to look at the very violent history of American gynecology and this notion that Black women are less likely, but don't experience pain as much as white women, and all the horrific quote unquote surgical experimentations, but really torture that happened to Black women's body in the name of science. But it was all based on this notion that Black women have higher pain thresholds, and that legacy and notions that Black patients have higher pain thresholds, we know persists today amongst medical practitioners. And then I am using my last slide to shamelessly plug another event. We've got this conference with funding from the British Academy called Reframing Endometriosis, Power, Politics, and Potential Futures. And it's going to be really interesting in that we're bringing medical anthropologists, historians, together with linguists, but also biomedical genetic researchers, patient advocates, and more, to talk about previous framings of endo, current ones, and what could happen in the future and what needs to happen in the future. And then my last plug is, if you'd like to know more about the work that we're doing, you can email me, I'll put that in the chat soon, to join the Social Sciences Endometriosis Network. And that's it from me.
Thank you so much, Annalise. And that finishes up our presentations today. So I will be asking our panelists to please turn on your camera and your microphone. And I also encourage attendees to please include your questions in the Q&A. So we have a few questions already, so I'm going to launch into those to make sure that we are prioritizing attendees. So for our first question, this is directed towards Jane. Such a fascinating talk, Jane, and I have lots of questions, But let me ask this. What do you think are some of the key research questions to be asking about chronic pain and gender in relation to transgender and non-binary communities?
That's a really wonderful question, and I think there's a lot of space for, as I mentioned, kind of developing research projects in this area. I think one place of just continuing to be able to use kind of thinking through what is social and what is biological, right, is so central to transgender theorizing. There's so much great work done by transgender sociologists in the sociology of health and illness around transgender issues, a lot of feminist and queer scholars working on some of these questions. And I think using some of these frameworks of understanding how kind of mainstream biomedicine is adapting to the activism of transgender and non-binary folks, showing us the interesting ways that biomedicine is able to move beyond these kind of heteronormative binaries in some instances while reinforcing them in others, can help us really get a handle on what's going on with pain with reference to how pain specialists are thinking about the origins of something that is so clearly biopsychosocial as chronic pain as being either biological or social, and having a very difficult time kind of piecing together that nexus. So I think that just theoretically, it's a really interesting space to be thinking through some of these questions. But then also we know from work in the sociology of health and illness that some of the medical interventions that transgender folks go through for gender affirming care oftentimes can lead to chronic pain, especially when those procedures are done by practitioners that might not have the sort of training that they need to be successful in those practices. So I think there's a particular actually growing chronic pain population related to kind of botched or unethical or poorly practiced transgender care. So those are just a few ideas, but I just really encourage folks to be thinking beyond the binary and thinking about the relationship between gender and chronic pain. Thanks so much.
Excellent. And again, just a gentle reminder to the audience members that we will be going past time today to ensure that we will be answering everyone's questions. So for our next question, this is directed towards Christine. Fascinating presentation, Christine. Can you speak a little bit about the challenges and benefits, of course, of conducting feminist ethnographic work in clinical settings?
Yeah, that's a great question, Fiona. And I thought about two things as I read it. One, which is the sexual medicine class that I teach every other year for about the last decade or so, where I really try to put students, gender studies students, into conversation with students thinking about medical careers, and us sort of taking on sexual medicine topics together, so that the kind of clinically oriented students learn from the gender studies students and vice versa. And we really try to unpack and sit with some of the difficult, less answerable sorts of dilemmas and questions that we think through. So I have some optimism and hope about more clinicians who we might encounter, as people that we want to conduct research alongside, being more attuned to some of the kinds of questions that we ask, and some of the ways I think that feminists think about and ask questions, particularly around gendered medical situations. And then I'm glad that that this is a nice response to Jane's question, because I thought about Georgianne Davis's book, Contesting Intersex, which a lot of you I'm sure have seen, and she does talk about it's sort of my optimism about my students is kind of addressed by Georgianne in that book a little bit, which is that there are many of the clinicians that that she worked with took these gender studies classes in college, and then sort of all of that training went away during medical school. And then they become physicians, and they're like, no, I work with a binary, right? And so I guess I think about those are both the challenges and the benefits, right? That it's just kind of an ongoing active translation, I think, between us. And I felt really lucky because I had some legitimacy in some ways to the clinicians that I worked with because they could recognize me as a clinician. But then they would, kind of have expectations of me in my role at the clinic as a participant observer that I would say, no, I'm not a clinician here. I'm an anthropologist. That's a different kind of set of questions I'm asking. So, but I think it's I think we're staying in this space of translation, and that is, again, I think it has both edges, right? So as long as so it's an opportunity for us to continually reassert and reiterate the kinds of questions that we ask, with, I think, increasingly with clinicians who are increasingly attuned to those or have been exposed to them, but who have all kinds of other pressures in their, in sort of clinical spaces to collapse and reduce and, kind of decomplexify what we are constantly trying to complicate. So yeah, I think we all, feel that. So thank you, Fiona.
Excellent. Wonderful. Okay, and our next question is for Annalise. What is next for you in relation to this work? I will be extremely interested in following it.
Me too. Once I can find funding, yes. Really, what we're trying to do with the SCENE network is we noticed that all these social scientists and humanities researchers doing work on endo are operating in silos. And what we really want to do is bring us together to find out what the priorities that we need to go investigate next. Just like clinical medical research, most researchers are in the UK, Australia, United States, and Canada, and we're really trying to reach out to those researchers in the global south next. And the real next step that needs to happen with qualitative work generally around experiences of endometriosis is with ethnically minoritized communities whose voices are missing, with trans, non-binary, intersex communities whose voices we still don't know of any qualitative research, whether there's like little literature reviews, etc. But that work has to be done with researchers from the community. So us sociologists, medical anthropologists, because we ourselves are not because of all these structures from those communities, we have unintentionally replicated this notion of a career woman's disease, because the vast majority of narratives we have are with cisgender, white, middle-class women that we currently have as evidence. So that's one area that I'm pushing. And the next one is really, really trying to break down the divides that we have between the social sciences and the biomedical research. And that's, of course, the big one, but we're always moving towards that. And the reason I'm talking about that, it's about getting into the room with the patient and the doctor. And I'll just talk a bit more, like Elaine, she's done all this research on endo. And I said, I'm tired of collecting these stories of trauma, of these stories that we already, like these stories, ongoing stories of trauma. I want to talk to the health practitioners. I want to talk to the doctors. What are their views? What are their challenges when someone presents with these very complicated symptoms? And Elaine told me I wouldn't get them. The doctors are used to being the people who do the research, but not the researched, right? And there have been people that have broken through. Dr. Veronique Griffith did the first ethnography on endometriosis, but she herself started as a medical doctor. So you also have to be from that community to be able to enter that community. But I was asked to write a piece on all these common denominators around why women are dismissed around pain, not just from endo, but other symptoms, and then asked to continue. This is a piece for the conversation for a more public audience, like what works, to give what tips work. And we're always in the conversation, everything has to be evidence-based. And I said, we don't have the evidence base for what works. And so that is another thing that I'd like to explore. So I've just given a whole bunch.
Wow, it's fascinating. Thank you. Okay, so we have one more question from the audience. Congratulations to all the presenters. I have a question for Jane about clinicians in France prescribing increased socialization for some patients with chronic pain. What does this look like in practice? And is there any pushback from patients?
That's a really great question, Craig. And I would say that the idea of prescribing it, I think the way that you phrase that is really interesting, because I will say that this came up as something that I don't think the French pain specialists themselves were saying, they weren't saying outright, like, I tell my patients that you need to do this. But what they talked about was gently encouraging them over time with each visit to, hey, have you thought about, perhaps going back to school? Have you thought about joining this community organization? This is not all clinicians, right? But many of the pain specialists that I spoke to in France were more attuned to these issues of trying to nudge their patients into, encourage them into kind of building community in a way that they thought would help them psychosocially begin to manage, not cure, but manage and learn to live with their pain. And they really talked about how there was a stark difference between how they felt men recovered faster because they tended to be plugged into those networks, often through employment, but they also would cite things like sports or athletics. That they would say, we start to give some of these biomedical tools that ease the pain a little bit, and then these male patients they kind of jump back into their routines, their social routines, and they get better and we stop seeing them, whereas women tend to be in treatment for much longer. And so something that they also talked about was that they felt that the social interaction of the treatment itself was incredibly important for the women. And so that they actually spent more time in each clinical encounter just talking to the women about their lives, because they felt as though that actually was quite beneficial in itself. So I thought that sort of, self-awareness was really interesting, but I'm not sure that it's something that they really make. I did not do ethnographic observations with patients. I just did interviews with the specialists and then patients. And so I'm not sure that that's something that was necessarily made explicit to patients. But it was something that would come out on the clinicians reflecting on, I do actually treat my women chronic pain patients differently, and here's why. But thank you for such a great question. And I will say in general, patients in the US and France tend to push back a bit on sometimes these psychosocial interventions that are time intensive, often ignore the demands that are already on their time and resources. And so we're always in this sort of bind of how to support those more ongoing and gradual psychosocial interventions. Thank you.
Wonderful. Okay, well, that's it for our audience questions. So I think we'll end it here, unless there's any other final thoughts that any of the presenters wanted to add before we end. No? Okay, wonderful. Okay, so this concludes our session for today. Our next webinar will be taking place in September. So we will be off for the summer. Our September webinar will be focusing on critical disability studies and pain. So please be sure to look out for that. I want to thank everyone for attending, and I want to thank the panelists for their excellent presentations today. And again, please be sure to visit the CASPR website, that's criticalpainscholarship.ca, to register for future webinars, to learn more about this international community of practice, and of course, to access the webinar recordings. So thank you all very much, and have a good rest of the day.
Thanks so much, everyone. Great to meet you.
Thank you.
Thanks,
Take care.
everyone.